acute hepatitis. So this now we are coming to the conditions that we're talking about. And I remember telling you that generally in all conditions, when you look at any system in any tissue, you always want to think of conditions that either can be even congenital, because anything can have congenital anomaly. The formation of the liver can be abnormal. So you can have congenital anomalies in any organ, any part of the body. You also need to think of disorders as it could be inflammatory. Disorders also of any organ could be tumors. So it could be cancers, it could be non-cancerous tumors. It will also be infection. Remember, even the liver can also be affected by infection. Likewise, the liver, the pancreas, any of those organs can have infection. And then there can be metabolic conditions. Like, for example, if you're looking at the pancreas, if you have a problem with production of insulin, then you end up with diabetes. That is a metabolic condition. So it can affect the liver, it can affect the kidney. Then you have also, you can have iatrogenic. As I said, it is caused basically by by healthcare workers, probably healthcare practitioners like doctors, nurses. When you are trying to intervene for something else, then you can end up causing a problem. For example, for me as a surgeon, I probably will be doing surgery and injure something. And so that will be called iatrogenic. So conditions can be iatrogenic. Or during when you're giving medications, a medication can cause problem. And so that will be iatrogenic. Of course, you can have trauma. Any organ, much as I have not mentioned trauma of the liver, but liver, we see liver lacerations or injuries during, for example, road traffic accident. We also see sometimes during trauma, you can traumatize the pancreas. So trauma, anything that can injure the liver, it can injure the pancreas, it can injure those ducts. So trauma is very important. It can affect any part of our bodies. The bones, remember for bones, you have even fracture of bones because of trauma. And then you can have a condition because of vascular. You can talk of a condition being resulting from vascular situation. For example, if you cut the blood supply to the liver, then the liver cells will die because there will be maybe there will be ischemia, there will be necrosis, and so on. And that will be because we have cut out the blood supply to the liver or to the pancreas. So any organ, because all organs will have blood supply and it will have venous drainage. So that is the way to think of any organ. So of course, some things we will not be able to say in this particular presentation because it's very wide. So I brought in what I thought was very important. And of course, the one that will be here, you require to read around them because this is most likely the ones that I will set in the exams. I'm already setting your exams. I think I'm almost done. I mean, that the scenario we have, but all the same, we are setting exams for you guys. So it will mostly be from what I've mentioned here. So read around this, but there are many other conditions that can affect the liver, which you'll be able to get to know as you move on in the years. So basically, when you look at hepatitis, it refers to inflammation, although it doesn't necessarily mean it has to be infection. Anything can cause inflammation. I think you need to go back. Acute inflammation, look at basically the inflammation, that many things can cause inflammation. So we're talking about the liver, you can have either acute hepatitis or you can have chronic hepatitis. So in case of acute hepatitis, and remember when you're looking at pathology, you want to be able to ask the question, what complaints will the patient come with? Abdominal pain, things like that. And then if I'm to examine this patient, what am I likely to see? That is the examination. And basically, when you look also at pathology, you should be able to explain why you have those symptoms and you have those signs. Why does somebody have abdominal pain? You can be able to explain, in this case, for example, that there is inflammation. And one of the features of inflammation was pain, fever, all those. You should be able to go back and look at them. And also another thing when you're doing about pathology, also remember there is the microscopic anatomy, where you're looking at things under the microscope. So like cloudy swelling, fatty change, which we talked about, liver cell necrosis. These are not something that you will see with a naked eye. This is something you will have to look at the microscope. So if you are to look at the microscope in a scenario where somebody has acute hepatitis, you see the cloudy swelling, fatty change, which we already mentioned. Just go back and refer to Pathology 1. As I said, it is building on it, so we don't discard what we did in Pathology 1 because it's important, is because we are building on that to understand it. So go back again and look at Pathology 1, those changes that we talked about, liver cell necrosis, so you'll see under the microscope. And there are very many causes. Yeah, it could be exposure to certain drugs. There are some drugs that are hepatotoxic. And that is why, even I'm sure you're doing pharmacology, you cannot just give any drug to everybody or to the duration. You have to be careful because there are some drugs that are hepatotoxic. That is, they can injure the liver. Yeah, it could even be poisons. Yeah, or it could be part of fulminant viral infection. When you talk of fulminant, is severe infection by viruses. Yeah, it may resolve or persist as chronic hepatitis. So acute hepatitis can actually just heal, but it can also persist as chronic hepatitis. So when you talk of acute hepatitis, you're basically a general term for inflammation of the liver parenchyma. Remember we talked about parenchyma, which is the substance where the hepatocytes will be. When you talk about the stroma, you're talking about the connective tissue. So usually they is marked by focal accumulation of inflammatory cells, usually in relation to necrotic hepatocytes. So there will be necrotic hepatocytes, and those ones will attract, of course, inflammation. So there will be inflammatory cells, like neutrophils and so on will come there. And you remember, you know the functions of those, what they're supposed to do. So if you have to look, and this is, of course, looking under the microscope. And you are likely to form abscesses, that is pus. Yeah, so they are likely to form hepatic abscess. Most of the time it will be within the biliary tract or septic focus in the abdomen. So it could be within the biliary tract. Those biliary tract, we are talking about the bile canaliculi if it is within the liver. If it is outside the liver, those are the extrahepatic bile ducts, like the common hepatic duct, the right and left hepatic ducts, the common bile duct, and so on. So infection and pus can even accumulate in any of those. But also, you can have infection actually within the abdomen. Yeah. And of course, etiology is the causes. So some of the causes will be viral. Those are viral infections. Remember the hepatitis viruses, A, B, C, D, up to E, and I think the others also. It could be toxins. For example, one of them that is been identified would be alcohol. So somebody who takes excessive alcohol is likely to cause acute hepatitis. Also drugs, some drugs that I've already mentioned, something like halodane. Halodane is a drug that is used as in anesthesia. It's one of the drugs that is commonly used when somebody is under general anesthesia to keep somebody asleep so that they don't feel pain during surgery. But of course, it can harm also the liver. Isoniazid is a drug that is used in tuberculosis. One of the drugs that are used in tuberculosis called isoniazid. So if it is used excessively, it can also injure the liver. Also, systemic infection, that is basically infection that affects the rest of the body, can actually cause injury to the liver as well. Something like Leptospira, you'll be able to look at them. I think it's a type of bacteria, Toxoplasma, especially in disseminated disease. Yeah, Toxoplasma that is disseminated, that is, it is spread all over the body. It can affect the liver. You can have bacterial septicemia. Because septicemia is infection. Mostly it will be within the blood that spread all over the body. And also miliary tuberculosis. I think we talked about miliary tuberculosis last time, that it can affect the liver and so can cause acute hepatitis. Then we have viral hepatitis. We said one of the causes of acute hepatitis, of course, could be viruses. And these are the viruses that we call hepatotrophic viruses. That means they tend to have a predilection. I think they tend to infect the liver mostly. That is what they mean by hepatotrophic. So there is virus A, B, C, D, E. Hepatitis A, hepatitis B, C, D, they're all those. Or others like cytomegalovirus, CMV, Epstein-Barr virus, and HSV. Those are just types of viruses that can affect the liver and cause viral hepatitis. So something to note is hepatitis A and E, the way they are spread, basically they are spread through contaminated, maybe water, contaminated food, and so on. So we call it fecal-oral transmission. Yeah. And usually hepatitis A virus and hepatitis B, they rarely cause chronic hepatitis. There is no chronicity. That means they rarely cause chronic hepatitis and or carrier state. Carrier state is a scenario where somebody has an infection, they have the virus. For example, even some people have, for example, people who have typhoid, they may have the typhoid bacteria, but they are not sick from typhoid. But the thing is, they can spread it. So that's what we call carrier state. You have the virus in your body, but it's not causing infection, a disease in you, in the person, but you can spread it to other people. So that's what we call carrier state. So this one, hepatitis A and E, rarely causes that carrier state or chronicity. And usually it tends to be mild and self-limiting. Self-limiting, basically, if you leave it alone, even if you don't treat it, it tends to heal. It's just like common cold, that if you don't treat common cold, it's probably going to heal. We call it self-limiting. So in hepatitis B, you can see in bracket D and C, are bloodborne. That is basically they can be spread through blood. They are bloodborne. It can also, that is basically body fluids. Even in saliva, it can be spread. Even through semen, so through sexual intercourse, you are likely to get it. So body fluids. It can also be spread in chronic hepatitis. So this one, usually this hepatitis B, and in bracket D and C, they can lead to chronic hepatitis and carrier state. So somebody may even not be sick from this, but they can actually spread to other people. In cases of needle sharing in cases of where people have drug abuse, for example, people are injecting cocaine or any of those drugs that are injected. Some people sometimes, because they are of an addiction, they actually share needles. And so that in itself can spread hepatitis. Also sexual intercourse, because as I said, it can be spread through semen, even transfusion. And that is why generally I believe all of us, you are supposed to have been immunized or vaccinated, hepatitis B vaccine. I'm sure most of you or all of you should have been given, because especially that you will be dealing with patients who may be having hepatitis. So you are likely to contract it as a result of that, because of your work. Yeah, because of your occupation. And that is why all of us ideally should have hepatitis vaccine to prevent us from getting hepatitis B. So hepatitis B, the reason why we put in bracket there, is pathogenic only in association with hepatitis B. That means hepatitis D alone cannot cause disease. It needs to be either together with hepatitis B. So it could be somebody who has hepatitis B who get infected with hepatitis B, or somebody had hepatitis B and end up getting the hepatitis B infection, is when now they become sick. So it's only hepatitis B that will cause sickness, but hepatitis D alone will not cause an illness. So that's what basically we mean by hepatitis D is pathogenic only in association with hepatitis B. So if you look under the microscope, if you take a tissue of the liver, somebody who has viral hepatitis, and look at it, prepare it and look at it, you'll see widespread swelling and ballooning of hepatocytes. Hepatocytes are liver cells owing to hydropic degeneration. So go back and look. I think we talked about hydropic degeneration in Pathology 1, and this progresses to focal or spotty necrosis throughout the lobule. So there'll be some spotty, that means there are small necrosis all over the lobule. We are just continuing with viral hepatitis. There will be areas of, then in hepatitis B, C, and D, activity may persist and the disease may progress to chronic hepatitis. So B, C, and D can actually progress to chronic hepatitis. So when you find this what's called Cancelman bodies, they are indicative of more severe liver cell injury. So if you do histology and you're able to see these bodies, then you know that is a severe liver cell. The injury was severe. Of course, there is a diagram there on the left side, on the right side of your that picture, we have a micrograph. That is a picture under the microscope, and you can see it's stained with HNE, hematoxylin and eosin staining. And then, of course, the left side is the diagram where you can see some of those things that we mentioned, inflammatory cells, because anything necrosis will attract those inflammatory cells. There is the Cancelman body, you can see it there. There will be necrosis, this is the dropout necrosis. Kupffer cells, hyperplasia, that means the macrophages within the liver increase in number. Of course, there will be regeneration, that means new cells are being formed. And then ballooning degeneration will also be there. Yeah, so those are some of the things that you're likely to see if you look at the microscope. Then we have alcoholic liver disease. As we said, one of the things that can bring hepatitis or inflammation of the liver would be alcohol. So it's an important one. So we talk about alcoholic liver disease. There's steatosis, basically fat droplets in the hepatocytes. There's the fatty change. And then, so you start with the fatty change initially. That is the fat droplets in the hepatocytes within the liver cells. Then if it progresses, it goes on to become steatohepatitis. So you have ballooning degeneration, which is hydropic degeneration. You have neutrophils. We have what's called Mallory's hyaline. So that is steatohepatitis. Then it can progress on to have fibrosis, or you are likely to have fibrosis, which can go on to become cirrhosis. Yeah, so initially perivenular, that is around the veins within the liver and around the cells, pericellular collagen. So initially that, and it moves on to involve the rest of the liver. So Mallory's hyaline is enophilic material in the hepatocytes derived from cytokeratin intermediate filaments. So go back and look at the cells again. I think we talked about those filaments, intermediate filaments. And they form irregular cytoplasmic globules, usually near the nucleus. Note, the presence of fatty change in a non-alcoholic is an indicator of continuing alcohol intake. So I think I left out of continuing. So if you see somebody probably who have said they have stopped taking alcohol, and you look at their liver and then you see fatty change, it means that person is continuing to drink in spite of the fact that probably they are saying they've stopped drinking. It will be a sign of continuing alcohol intake. So an indicator of, so that is there is an of there, of continuing alcohol intake. Yeah, so and also of note, when you talk of basically steatosis, you're talking of fatty liver. Yeah, so if you are to progressively, you have alcoholic, if you're taking alcohol, and then so initially you will have the fatty liver, steatosis, and which can progress to alcoholic hepatitis, and if it's not stopped, then it will move on to alcoholic cirrhosis. Cirrhosis basically will be like scarring, which involve the entire liver, and so you end up with, that is how liver failure occurs. Usually the final part will be cirrhosis. And you can see there that diagram showing the fatty liver, alcoholic steatosis. You can see the fat cysts, you can see the central vein there, macrovesicles, portal triad. Portal triad is basically where the bile duct, the hepatic artery, and the branch of portal vein would be. That's what we call portal triad. And again, just another diagram showing the main features that you will see in alcoholic hepatitis. You can see, for example, the infiltration by neutrophils. There is a fatty change. That the Mallory's hyaline, alcoholic hyaline, those structures are reviewed, and this is microscopically, and ballooning degeneration. So in pathology, of course, there is a microscopic picture that you look at the microscope, and then there is the grossly. If you have to look at, for example, a liver that has cirrhosis grossly, you can be able to see. But of course, if you do histology, then you're able to see these microscopic features. Then there is what we call an alcoholic fatty liver. disease. So you're likely to have also fatty liver disease, but not related to alcohol use. But it will have the same morphological spectrum as alcoholic liver disease. So it will have all those other features. And this one usually is associated with obesity, dyslipidemia, that means the problem with lipids. So somebody may have high cholesterol within the blood and so on. That is abnormal lipid level in the body. That's what we mean by dyslipidemia. So somebody who is obese is likely to develop non-alcoholic fatty liver disease. NIDDM is non-insulin dependent diabetic mellitus. We call it type 2. For diabetes, we have type 1, which is insulin dependent, and then type 2 is non-insulin dependent diabetes mellitus, type 2. And in type 2 diabetes, mostly the issue is not lack of insulin. Usually it is the body is resistant to insulin. Yeah, so it's also associated with obesity, dyslipidemia, and type 2 diabetes, that is non-insulin dependent diabetes mellitus. So this one occurs in absence of excessive alcohol intake. Of course, somebody may be taking a little alcohol, but it's not excessive. But somebody has, when you check, they have fatty liver. So usually this one is diagnosed incidentally due to discovery of the liver function test upon routine blood testing. So in this case, it is incidentally discovered. Maybe somebody had another issue, then you decide to do a liver function test. Then you realize the liver function tests are deranged. And then now you find out only to discover this person has a fatty liver. And yet they don't have a history of excess alcohol use. And in this case, patients may have no symptoms or clinical signs of liver disease at the time of diagnosis. So at this, somebody may not have any symptoms that suggest there is a liver issue. Then, of course, we move on to chronic hepatitis. Remember, most of those causes of hepatitis, they're not controlled early, or they may move on to chronic hepatitis. And I think we've talked about the viruses that generally lead to chronic versus those that rarely result in chronic hepatitis. So basically, this is if the hepatitis is persisting for more than 6 months, then that will qualify as chronic hepatitis. And there are very many various causes. And when you talk at this, it can affect the portal. Remember the portal triad, that is around that portal triad where the bile duct will be, the portal vein, a branch of portal vein, and a branch of hepatic artery. So it can affect those portal triad. So that we will call it portal. Then interface is between, those portal triads. We call it interface. Or you can talk of lobular inflammation. And when you look at those, when you consider the interface, portal, lobular inflammation, you come about the grade of the disease. So how much the disease, the grade of that disease. And then the extent of fibrosis. So inflammation, and part of the healing will be, even as we talked about wound healing, will be fibrosis. That is the formation of a scar. So when you look at how much a scarring has occurred, then you are talking about the stage of that particular disease. So in chronic hepatitis caused by hepatitis B virus, the cytoplasm of hepatocytes assume a pale pink ground glass appearance caused by accumulation of viral proteins. So there is what we call hepatitis B surface antigen, HBsA. So there is that accumulation of that protein, viral proteins, within the hepatocytes, cytoplasm of the hepatocytes. So it causes it to have a pale pink ground glass. I know all of us have probably have seen ground glass. Yeah, I think find out what a ground glass looks like. It will not be a very clear glass. It will look almost not clear. You're not able to see clearly through it. So basically, that's what we mean by ground glass. So in developing world, that is for third world, we can talk of third world and other places like Kenya and so on. That is what we call developing world. Transmission of hepatitis is commonly from mother to child. We call it vertical transmission. Yeah, basically in a pregnant mother, those hepatitis viruses are likely to cross the placenta and actually infect the child. That is what we call vertical transmission. Even in cases of HIV infection, one of the way we try to prevent transmission, but it can actually, HIV positive mother can transmit viruses to their child inside the uterus. That is what we call by vertical transmission. So in developing world, this can actually be spread to the child before they are born. if the mother is infected. So cirrhosis is a major risk factor for the development of hepatocellular carcinoma. So of course, chronic hepatitis can lead to cirrhosis. And cirrhosis is a major risk factor for developing hepatocellular carcinoma. So somebody who has cirrhosis, there is high risk of developing that carcinoma. And of course, this chronic hepatitis can be caused by viral infection, can be caused by autoimmune disease. That is basically the body forming antibodies against self proteins or self that is able to attack its own self. So autoantibodies. It could also be toxins. It could also be metabolic. All those can cause chronic hepatitis. And if you are to look under the microscope, there will be presence of inflammatory cells. Mainly will be lymphocytes. Remember, you go back and revise again the chronic inflammation. So, and these lymphocytes, this inflammatory cell will be most of the time in the portal tracts. Those are, when you talk of portal tract, you're referring to the portal triad. That is where we have bile canaliculi, we have a bile duct, and we have portal vein, we have a branch of portal vein, a branch of the artery, and even the bile duct. That's what we call portal triad. So it's likely to affect that region. Or they can be scattered within the liver lobules or both. Yeah. And of course, in chronic hepatitis also we have, if the disease progresses, then you are likely to end up with necrosis. That is the death of hepatocytes, either concentrated upon the limiting plate of the hepatocytes around the portal tract. So it can be limited to around the portal tracts. We call it interface hepatitis, or scattered within the liver lobules. Call it lobular hepatitis, or it could be both. So presence of fibrosis either in the portal tracts or extending from the portal areas into the adjacent parenchyma and short septa, or forming breaches across the lobular causing architecture. So this one, there'll be fibrosis either within the portal tracts or extending from the portal areas into the adjacent parenchyma, short septa, or forming bridges across the lobular structure. So this one usually, because it's basically fibrosis like scarring, it will end up causing architectural distortion. That is basically the architecture of the liver end up being distorted because of fibrosis. You know, one of the things about healing with fibrosis is that there's contraction. Yeah, and that is why the wound, once it heals, you are able to have distortion because of those fibrosis. So when you look at the assessment, when you do assessment of these features, can be used to determine how active the disease is. Remember, I talked about the grade and how far the disease has progressed. So when you want to know, for example, how much fibrosis has taken place, then that's what you call a stage. So you should be able to determine whether the disease is active. Yeah, that is what we say as grading, and then how far it has spread, how much fibrosis has taken place, and we talk about the stage. So staging and grading necessary for treatment and likely disease prognosis. So when you stage and you grade, it helps you to in treatment. That means basically if it has progressed so much, then you will not, because if it is in severe cases, you are likely actually the only treatment probably would be liver transplant. So grading and staging will help us to know how to treat and even to know the prognosis. That if there is severe fibrosis, then you know the prognosis is poor. If the disease is still acute, then you know that's a good prognosis. So grade usually is used to reflect the severity of any ongoing inflammation and necrosis, and then a stage is a means of assessing the degree of damage to the connective tissue framework of the liver. So staging, you're looking at the connective tissue, and when you talk of grading, you're looking at the severity of ongoing inflammation or necrosis. There's a diagram there showing a chronic hepatitis where you're looking at, you can see the diagram on your left is the normal. So that will be a normal lobule. Yeah, where you see the central vein, you see the portal tract, where we have the portal vein, we have it a lobular bile duct, and we have even the branch of hepatic artery. That is what we portal tract. And then you can see the limiting plate, that is the cells around the portal tract, is what we call the limiting plate. And then, of course, you can see there will be sinusoids there, and finally blood flowing into the central vein. And then on the right, B. So the A is normal, B will be the abnormal one. So if you have to look at that, these are diagrams. So you can see proliferated bile, that is bile ductules. So the bile ductules proliferate, so that is B-I-L-E. So proliferated bile ductules. So bile ducts increase in number, so they proliferate. And then another thing that is likely to happen in case of chronic hypertension, you're likely to see necrosed hepatocyte. That is basically liver cells that are dead. And then there is that inflammation basically around them. Remember, this is called portal triad. So if you talk of triaditis, there is inflammation around there in the portal triad. And there you're likely to have lymphocytes, plasma cells, and macrophages if you have to look at them. And also the portal triad is likely to expand because there is increase in number of cells around it, and so it's likely to look expanded or to expand. Remember, there is even proliferation of ductule, so the portal triad expands. Yeah. And then those cells that were around, the one we were calling limiting plate, have been destroyed because there is necrosis. So there is destruction or there is erosion of the limiting plate. And then, of course, you can see the bridging fibrosis. Basically, you can see fibrosis that bridges or connects the portal triad with the central vein. So there is that bridging fibrosis, basically formation of scar. And then sometimes you can have focal necrosis. That is basically some death of just localized hepatocytes in one place.